Hello everyone. So we will be continuing with management of asthma, the chapter 17 of illustrated textbook of pediatrics and medications used to treat children with asthma are shown in table. A wider range of biological treatments are becoming available, but these are only required for a small proportion of asthma patients. In the table, causes of declining persistent channel wheeze, viral sodic wheeze, viral fibril wheeze, asthma, recurrent anaphylaxis, and food allergy, chronic aspiration, cystic fibrosis, bronchopulmonary dysplasia, bronchiolitis obliterans, tracheobronchomalacia. The drugs in asthma, type of drugs, bronchodilators, which are salva and lava. Short-acting beta-2 agonists, rescue inhalers, which are salmeterol and terbutaline. Long-acting are salmeterol, formoterol, anticholinergic bronchodilators, clotropinamide. Preventive therapy, inhaled steroids, budesonide, beclomethasone, and fluticasone and mometasone. Astaxanthine, theophylline, leukotriene receptors, antagonist, Metallica, oral steroids, anti-IgE, monoclonal antibody, omalizumab, and anti-IL-5 monoclonal antibody is natalizumab. Bronchodilator therapy, inhaled beta-2 antagonists are the most commonly used, the most effective bronchodilators, short-acting beta-2, which are restful inhalers, so the salbutamol, terbutaline have rapid onset of action, maximum effect after 10 to 15 minutes, are effective for 2 to 4 hours and have few side effects. They are used as required for increased symptoms and in high doses. For acute asthma attacks, use of ASAVA more than 2 times per week should prompt the need to start preventive therapy. Some international guidelines now recommend that these should not be used alone to treat asthma when the class of inhibitor antagonists, such as salmeterol and formoterol, are effective for 12 hours. They are not used in acute asthma and should not be used without an inhaled corticosteroid. Use as single treatment is associated with increased mortality. And LAVAs are useful in exercise-induced asthma, and protonolomide and anticholinergic bronchodilators sometimes given to young infants when other bronchodilators are found to be ineffective or in the treatment of severe acute asthma. Preventive therapies and inhaled corticosteroids, prophylactic drugs, are effective only if taken regularly. Inhaled corticosteroids, often called preventers, are the most effective inhaled prophylactic therapy. They decrease airway inflammation, resulting in decreased symptoms, asthma exacerbation, bronchial hyperactivity. They have no clinically significant side effects when given a low dose, although they can cause mild reduction in height velocity, but this is usually followed by catch-up growth in later childhood. Systemic side effects, including brain growth, adrenal suppression, and bone metabolism, may occur when high doses are used. The next ones are to reduce risk of side effect treatment with inhaled corticosteroids should always be at the lowest dose as possible. Treatment for many children is effective very low dose. Always monitor the dose of children with asthma, especially if taken regular or inhaled or oral corticosteroids. Add-on therapy, the first choice of add-on therapy in a child over 5 years is LAVA. Wherein children under 5 years, oral leukotriene receptor antagonists such as Metallica is recommended. The latter can also be used in condition where symptoms are not controlled by elation of NABA slow release oral chain kinase in the alternative. However, its use is limited in children by the highest incidence of side effects, vomiting, insomnia, headaches, food constriction. Antibiotics have no volume value in absence of bacterial infection, neither of medicines nor decongestant are beneficial. Antihistamines such as Loratadine and nasal steroids are useful in treatment of allergic rhinitis. Now, MART therapy, there has been recent move towards the use of combined IV corticosteroids and lava inhalers and maintenance ventilator therapy. Most regimes require a small regular dose of ICS and lava to be given with scope up for increasing daily dose up to 4-fold of required. There's a little evidence this approach is effective in children and young people, and the potential benefits are extrapolated or else releasing observation data. Additional therapies for children and young may be swears and oral prednisone usually given on alternate days to minimize the adverse effect on growth. As well as only in severe persistent asthma where other treatments have failed. Injectable monoclonal antibodies that act against IgE minus around 18.5 is a mechanism and also will effective to the severe asthma. IgE is a natural antibody that mediates allergy, and IL-5 is a cytokine which that mediates eosinophil population. Children requiring this treatment should be managed by the specialist pediatric asthma service. Escalating these related treatment, which guidelines on asthma management uses a stepwise approach, starting treatment with the step most appropriate to the severity of asthma and aiming for optimal control of the symptoms. Complete control is defined as absence of daytime or nighttime symptoms, no limit on activities, including exercise, no need for daily use, normal lung functions, and no exacerbation with saturation of steroids in the previous 6 months. Once a diagnosis has been established, all children should be on regular preventive. Treatment is stepped up when asthma is good and stepped down when control is good. For children 12 years and younger, the current guidelines summarized in this picture. Older children should follow adult protocols and guidance, which typically use higher doses of inhaled corticosteroids and a greater range of biologicals. Now, this treatment of asthma suspected, and pediatric asthma diagnosed, and diagnosis, evaluation, assess symptoms, measure lung function, check inhaler technique and adherence, adjust dose, update asthma plan, move up and down as appropriate. Consider monitored initiation of treatment with very low to low dose inhaled corticosteroids, short acting beta technical is required. Consider moving up if using the up versions are there. Infrequent short-lived V's, regular preventers, very low pediatric dose, or LTRA less than 5 years. Initial add-on on therapy. Move down to find and maintain lowest control and move up to improve control as needed. So we move up from regular preventers to add-on to very low ICS plus in LTRA in less than 5 years and more than 5 years at one day LAMA or LTRA. The district control will consider increasing ICS to low dose. Shouldn't more than 5 years adding LTRA or LAMA. If no response to LAMA, consider stopping. Refer patient to specialist care, specialist therapies, and stepwise approach treatment of asthma in children 0 to 12. Very low dose includes doses up to 200 mics, and low doses are up to 400 mics of glycomethoxamine dye, propionate, CFC, MDI. Provenant per day. ICS inhaled corticosteroid, LDL leukotriene agonist, long-acting beta agonist. Allergy avoidance and other non-pharmaceutical. In children who have allergy to house dust mites, use of dust mining permeable bedding may reduce exacerbation of asthma, requiring hospitalization. Allergen immunotherapy is effective at treating atopic asthma due to a single allergen, but its use is limited by the risk of systemic allergic reactions associated with the treatment. Parents should be advised about the harmful effects of inhaling secondhand cigarette smoke and e-cigarette vapors. Acute asthma assessment. With each acute attack, duration of symptoms treatment already given and the course of previous attacks should be noted. Severity of an attack needs to be classified as mild, moderate, severe, life-threatening. The clinical feature determined as shown in the next picture. Criteria for admission to hospital. Children requiring estimation if after high dose inhaled bronchodilator therapy, they have not responded adequately clinically. There is persisting breathlessness or tachypnea, are becoming exhausted, still have a marked reduction in their predicted or usual best peak flow rate of FEV1 less than 50%, have a reduced oxygen saturation less than 92% in air. Chest section indicated only if there are unusual features and asymmetry of chest signs, the same pneumothorax, lower collapse, or signs of severe infection in children. Blood gases are only indicated in life-threatening or refractory cases and are often normal until the child is in extremis. Determine severity of attack. Determine the severity of attack. Mild, moderate, severe, life-threatening. Two breathless shocks where increased vocal breathing, check respiratory, arrhythmia varies with age, poor guide to severity. Chest recession, moderate, intercostal sessions, where use of excessive neck muscle, life-threatening, poor respiratory auscultation, wheeze, silent chest, poor entry from poor expiratory effort or exhaustion and life-threatening. And cardiovascular tachycardia varies with age, but is guide to severity than respiratory rate when affected by beta agonist. Arrhythmia, hypertension is life-threatening. Out of consciousness, agitation, and confirmed life-threatening exhaustion is life-threatening. Town sinus syndrome is life-threatening. Peak flow person predicted or best, but its usual moderate is more than 50, severe 33 to 50, life saving less than 30%. Situation model more than severe, life saving less than 92%. Is there a trigger for the attack of this or other viral illness, allergen, animal diet and exercise, and causes of acute breathlessness in the older children, asthma, pneumonia, or respiratory jacket, foreign body anaphylactic cells, pneumothorax, or fluid fusion, metabolic acidosis, diabetic ketoacidosis, inborn error metabolism, lactic acidosis, severe anemia, heart failure, panic attacks, hyperventilation. Management, acute breathlessness is frightening for both the child and the parents. Calm and skillful management is the key to their reassurance. Oxygen, inhaled bronchodilators, and steroids form the foundation of acute asthma attack. Management summarized in as soon as a diagnosis has been made, if the oxygen saturation is less than 98, oxygen therapy should be given. All children should be given a beta 2 bronchodilator dose and frequency is valid according to severity of the child, the child's age and response to therapy. It should be given with a meter dose inhaler and spacer unless the attack is severe to life-threatening or nebulizer driven by high flow oxygen may be indicated. Additional nebulizer protocol nebulized by initial two. An initial therapy in severe asthma is probably beneficial. Short course required is over penicillin expedites recovery in moderate to severe acute asthma. Inhaled therapies may not be delivered in therapeutic concentration to severely affected areas of the lung that are underventilated. So intravenous therapy has a role in the few children who fail to respond adequately to inhaled bronchodilator therapy. Magnesium sulfate, salbutamol, and aminophylline are all potentially beneficial. Magnesium sulfate is usually the first-line IV agent, but it can cause profound hypertension. Both IV salbutamol and aminophylline diluted dose is given over 20 minutes, followed by continuous infusion during which ECG and blood circulation should be monitored. If the child is already on theophylline, the loading dose of aminophylline should be limited. Nausea and vomiting common with aminophylline IV salbutamol can cause tachycardia and lactic acid. Antibiotics also only given if there are clinical features of the infection. Occasionally, these measures is sufficient and mechanical treatment is required. Patient education prior to discharge and patient of acute admission with college should be reviewed with the child and family. When drugs should be used regularly or as required, how to use drugs, immune techniques, what each drug does, relief versus prevention. These are the severity and moderate, able to, these are the symptoms, able to talk, which should be more than peak flow is more than 50, best respiratory rate, less than 40 breaths per minute for 1 to 5 years, less than 30 breaths per minute for 5 to 12 years, and less than 25 breaths per minute for 12 to 18 years. Heart rate less than 140 beats for 1 to 5 years, less than 125 beats for 5 to 12 years, and less than 110 beats for 12 to 18 years. So, 2 breathless to oxygen saturation for less than 94, less than 12-year-olds, peak flow 33 to 50, best. Respiratory rate more than 40 in 1 to 5, more than 30 breaths per minute, 5 to 12, more than 35. For heart rate is more than 140 for 1 to 5, 135 more for 5 to 12 years, and more than 110 for 12 to 18 years. Life threatening. Silent chest cyanosis, true respiratory chest exhaustion, arrhythmia, hypertension, altered consciousness, vegetation, confusion, peak flow less than 33, and oxygen saturation less than 92 in all ages. Management, high flow oxygen if available. Peak calm ratio, showering patient, short acting, beta-2 or spacer with face mask for those under 3. 2 to 4 pulse increasing by 2 pulses every 2 minutes to 10 pulses if required. Oral producer 1 to 2 mg per kg, maximum 40 mg. Monitor response for 15-20 minutes in high flow oxygen if available in severe. And short acting, spacer 10% nebulized 2.5 mg, salbutamol less than 18.5 mg, more than 8 years, assess response and repeat as required. Oral prednisolone or IV corticosteroid consider consider inhaled respiratory nebulized magnesium. I will immediately diagnose salbutamol, aminophylline, magnesium short acting nebulized 2.5 mg, salbutamol in less than 8 years, 5 mg in more than 8 years. A response continuously repeat as required, back to back, ropiconol, IV hydrocodone. Nebulized respiratory nebulized magnesium, IV beta to MS, salbutamol, aminophylline, magnesium, discuss with PICO. Assess reports responding, continue work on less than 1 to 4 hours. And Discharge when stable on 4-hour treatment. Continue over the discharge for 7 to 10 days at discharge to give medication and related to 5%. Nice asthma action plan, arrange appropriate follow-up, not responding transfer ratio, people ensure senior medical review, consider IV therapy is not already used, elimination manifolding, with awareness, consider chest X-ray to check for pneumothorax infection, blood gases, consider need for mechanical ventilation. How often, continuing with it, how often questions are to be asked, how often and how much can we use frequency, what would be explained to a patient and what to do with asthma worsen. Written personalized asthma action plan should be completed. The child and parents need to be aware that increasing symptoms, cough, fever, and breathlessness, reduced ability to participate quickly, and increased use of bronchodilators are all indicated fully controlled asthma. Some asthmatics find it difficult to identify gradual deterioration made of peak flow rate at home helps with this. Children and young people with difficult asthma may be given an emergency prior approach to treat at home and used for acute exacerbation as detailed in the asthma action plan. Outcomes are better for children with asthma or package of education measures, but no single component have been shown to be beneficial in isolation. Periodic assessment and review by healthcare professional is required as outlined for children who are old enough to perform outpatient testing. This should include spiral, choosing the correct inhaler. Inhaled drugs may be administered via a variety of devices chosen according to child's age and preference. Pressurized meter dose inhaler and spacer for all ages 0 to 3, spacer with face mask more than or equal to 3 years, spacer with mouthpiece. And spacer is recommended for all children as it increases drug deposition in the lungs and induces oropharyngeal deposition and therefore systemic side effects. Useful for acute asthma attack and poor inspiratory effort may impair the use of inhalers direct to the mouth. Breath actuated meter dose inhaler is an autoinhaler and ACP for from 6 years. Less coordinated meter dose inhaler coordination needed than a pressurized meter dose inhaler without spacing. Useful for delivering without an then out in a balloon. Dry power inhaler for 4 years. Need a good inspiratory flow, therefore less good inspiration during asthma attack. Also easy to use when out in a balloon motion. Nebulizer at any age. A far less efficient method of drug delivery than meter dose MDIs. The spacer, due to variation droplet size, should always be invested using high oxygen, not air. Only used in acute asthma where oxygen is needed, and many children fail to respond to treatment because the inhaler is not appropriate for the age or to have poor inhaler techniques. Inhaler techniques should be taught and assessed at every review. Dry powder inhaler, 4 years and older, is an nebulizer only used in acute asthma where oxygen needed in addition to inhaled drugs. Pressurized metadone in space, so the origin face mask is under 2 years of age. Now, the cough effects functions to expel unwanted material, including mucus from the airway below the glottis. In most children, episodes of cough are due to bronchial spreads of upper respiratory tract infection caused by viruses and do not indicate the presence of long-term and serious underlying respiratory disease. In about half of children with acute cough, the symptoms will settle by 10 days, but in up to 10% will persist for up to 4 weeks. Coughing following any respiratory tract illness tends to persist for longer if there is ongoing exposure to environmental cigarette smoke, as this impairs severe function. Significance of parental smoking on children is often underestimated. In both parents smoke, young children are twice as likely to have begun cough increase than in non-smoking households. In the only children, effective smoking is an important factor. Cough lasting more than 8 weeks is considered chronic. Periodic assessment of child with asthma. Clinical features of check, growth and nutrition, peaks of spinal to exhale, nitric oxide, chest for hyperinflation, heads and circles, peace. Are there any allergic to allergic rhinitis, eczema, food allergy? If atypical features persist, both on finger clubbing, growth failure, then seek another diagnosis. Monitor peak flow diary, severity and frequency of symptoms, exercise tolerance, interference with life, time of school. Sleep disturbed is appointed to new medication at the appropriate inhaler technique, consider triggers, and treat allergic rhinitis, allergic to cigarette smoke, stress check. Child has up-to-date post-line asthma action plan. Family have necessary medications equipment to manage an acute exacerbation. Chronic after causal listed in box. By far, the commonest reason for this is that the child has had a series of respiratory tract infections in rapid succession. This often happens when A child enters school or nursery for the first time and is much more common if there are older siblings. However, some infections such as pertussis and RSV and mycoplasma can cause a cough that persists for weeks and months, but eventually remits spontaneously. These coughs are typically dry, chronic wet cough, sounding like there is excess phlegm in the airways or productive cough after an acute infection may indicate unresolved lobar changes, following pneumonia, persistent bacterial bronchitis, or separated lung. If the cough is wet, sound like the excess phlegm in the area of the constructive, further investigations is required. Child really expectorates and therefore sputum is not commonly seen. Causes of chronic cough, recurrent respiratory infection, persistent bacterial bronchitis will be persistently wet, following septal respiratory infection, pertussis, RSV, and mycoplasma, asthma, accompanied by wheezing, persistent lobar collapse following pneumonia, respiratory lung infection, 65 versus cellular immune deficiency, recurrent aspiration gases, reflux, inhaled foreign body, cigarette smoking, active aggressive, TB, habit cough, and airway anomalies, sexual Malaysia, and tracheostomy fistula. Now, protracted bacterial bronchitis, floating is the leading cause of chronic red cough in young children less than 8 years in high-income countries. It is caused by infection of the connecting airways, trachea bronchi bronchitis, and catastrophic pneumonia, which is caused by infection in the air spaces. Affected children are otherwise well but often less cool and have disturbance. Causative agents include hemophilus influenza, strep pneumoniae, Moraxella catarrhalis, and Staph aureus. Maybe is a clinical diagnosis based on chronic wet cough, absence of symptoms of signs suggesting another partial bronchitis, and resolution of cough following antibiotic treatment. Although improvement with treatment is part of the diagnostic criteria, relapse of cough is common. Frequent relapse and recurrent PVB is associated with subsequent diagnosis of bronchitis. Less common cause of chronic cough, aspiration of feeds can cause cough, wheezing, recurrent lower respiratory tract infection. It can occur during or after feeding due to gastroesophageal reflux disease or swallowing disorders. Aspiration is more common in children with cerebral palsy. Really, it is due to an anatomical anomaly, S-type, tough, tracheoesophageal fistula, and inhaled foreign body needs to be considered in any cough with acute onset respiratory symptoms related to respiratory signs of a chronic cough with a persistent radiological abnormality. It occurs most commonly in children ages 6 months to 3 years. Aspirated material is often more most often food, but can be bits of toys or coins. A history of choking is present in more than 80%, but only when socially asked about. Radio-big foreign bodies can be readily identified on plain chest X-ray, as radiolucent foreign bodies such as a peanut is more difficult to diagnose. Removal is used by rigid bronchoscope. In any child with severe persistent cough, TB should be considered. This is showing a pin in the right main bronchus. Bronchiectasis is irreversible dilation of the bronchial tree, which can be confirmed on CT. In practice, is diagnosed by the presence of clinical features of chronic separated lung disease, namely recurrent episodes of chronic wet cough, striatal zone auscultations, and finger clubbing. It is confirmed by magical demonstration of bronchial dilatation. The early stages of bronchiectasis may be indistinguishable from PBP. There is evidence that mild bronchiectasis can be reversible if it be treated with suitable antibiotic or the causative factor. This is foreign bodies removed. Generalized bronchiectasis may be due to cystic fibrosis, primary severe dysfunction, immunodeficiency, or chronic aspiration. Focal bronchiectasis is due to previous severe pneumonia, congenital abnormality, or obstruction of foreign body. Treatment is based on optimizing airway clearance as well as the prevention of treatment of lower airway infections. Bronchoinjection CT of the chest, generalized with enlarged with the bronchi throughout the lung, left and right lung leads, and focal width changes in the right upward. Yes, the bronchiectasis, and this is foreign body of previously well choked on some peanut. His mother took him to the emergency where just as he was down, she was normal. She returned as he developed a severe cough and disease over the next 5 days, as being a radiolucent and inspiratory normal view and expiratory film need to be requested as a formality to assess a ball valve. And there is under expansion during inspiration, but poor expansion during expiration. Expiratory chest X-ray revealed hyperlucent right lung in gastric shift. Bronchoscopy was formed with peanut wedged in the right main bronchus. Now, this is fibrosis. Here is a common side limiting inherited condition. Caucasians, such as incidence of 1 in 25 and live births and carrier rate of 1 in 25, less common other ethnic groups. Average life expectancy has increased for a few years to the late 30s, with projected life expectancy for current newborn into 50s. Fundamental problem in CF is a defective protein known as CF, transmembrane conductance regulator, CFTR. This is the cyclic AMP dependent fluoride channel found in the membranes of cells. The gene for CFTR is located in kilograms. Nearly 2,000 different genes mutations have been discovered, causing a number of distinct defects in CFTR, but 5 are frequent mutation around 70% is PHP 508. Some genotypes are known to be associated with mild disease and pancreatic CFTR mutation can be grouped into 6 classes based on the way of CFTR protein is pathophysiology. CF is a multisystem body which results from the normal iron transport across the epithelial cells. In the airway, this leads to reduction in the airway surface liquid layer, causing impaired various functions and retention of thick mucopollution secretion, which are prone to infections. Defective CFTR also causes dissolution of inflammation and defense against infection. In this time, thick viscid meconium leads to meconium iris in 10 to 3% of infants, and pediatrics also become blocked with decreasing causing pediatric enzyme deficiency and malabsorption. Abnormal function of the sweat glands results in excessive concentration of lymphocyte in the sweat. So this is effect of different classes of mutations. This is normal amount of CFTR but reduced function. At reduced amount of function of CFTR genes, this is 1, 2, 3, 4. 1 has nonsense frameshift mutation, no protein synthesized. Incorrect folding cannot. Number 1 is nonsense frame. Incorrect folding cannot traffic and CFTR to right transfer. And incorrect folding cannot traffic to membrane. Number 3 is channel ethnic defect. And these are the 6 main classes. And number 4 is 4 abnormalities cause decreased conductance, and 5 is splicing abnormality, reduced protein synthesis. 6 is shortened half-life of protein. These are different class mutation. This is class 2 mutation. G551D is a class 2 mutation. New therapies that are within specific class 2 mutation are potentially major advance in treatment. Newborn screening. All UK infants are screened for CF as part of the newborn screening program. The test samples have elevated immunoreactive trypsinogen IRT to test with the common CFTR mutations. Second blood spot is obtained if IRT is elevated, but only one on a mutation detected. Infants considered to be at significant risk of the disease are referred to a specialist center for sweat test. Screening reduces diagnostic delay and lowers the risk of developing established lung disease or fortune. Diagnosis, the gold standard diagnostic procedure sweat test. Sweating is stimulated by applying a low voltage current to pyrocarbon applied to the skin. The sweat is collected in a special cavity tube or absorbed onto a weighed piece of filter paper and raised sweat chloride concentration more than 60 millimole per liter confirms diagnosis. Diagnostic errors are common if there is an indirect volume of sweat collected. Confirmation of diagnosis can be made by testing for CFTR mutations. Clinical features in the UK nearly all shown CF are now identified by newborn blood spotting screening in a handful of cases. It is the recurrent hand infection following malabsorption. CF lung disease is characterized by a vicious circle of infections, inflammation, and lung damage. Helicobacter pachymeles, Staph aureus, H. influenza, subsequent pathogen includes Pseudomonas aeruginosa and Mrcpch complex. And these infections can be eradicated if treated early. If not, the infection can become chronic, which is associated with lung damage, bronchiectasis, severe CF lung disease causes a persistent red curve productive of fluorescent sputum. It can also cause hemoptysis and pneumothorax. On examination, the stress hyperinflation due to air trapping, coarse, inspirating, respiratory preps, and respiratory wheeze.